So my name is Kimberly Blair. I am the manager of public policy and advocacy here at NAMI-NYC. I'm so happy to join our lovely panelists to discuss what is a great issue in our city, the increased criminalization of people living with mental illness and how to stop that moving forward and really change the landscape towards promoting recovery and public health for folks living with mental illness. We want to thank our co-sponsors of the event. We are part of the steering committee of the CCIT NYC, Correct Crisis Intervention Today, that promotes peer-led responses to mental health crises calls. We also want to thank the Police Organizing Reform Project, or PROP, of NYC. They have been a main player in organizing this event today, and we are so grateful to have them as our colleagues in this fight. We'd also like to thank Community Access, which is an awesome organization that already, community-based organization that has respite centers in the city for folks who are experiencing crisis and would like to connect with other peers for resources in a very, I guess, homey, so I can describe it, a very homey place. You can walk in and they're really taking and centering a person-first approach to mental health recovery. So we'd like to thank them. And so let's just jump in. Let's start talking about our panelists. Today we have our lovely panelists. First, I'm going to introduce Professor Alex Vitale. Professor Alex Vitale is a professor of sociology at Brooklyn College and coordinator of the Policing and Social Justice Project. He has spent the last 25 years writing about policing and consults both the police departments and human rights organizations internationally. He is also the author of City of Disorder: How the Quality of Life Campaign Transformed New York Politics and the End of Policing. He is also a frequent essayist whose writings have appeared in the New York Times, The Nation, and New York Daily News, as well as USA Today. Thank you, Alex. Next, I would like to introduce a colleague of mine, Felix Guzman. Felix is a poet, an organizer, a peer advocate who's working towards building healthier communities that are inclusive of all. Building positive conversation around issues of ending mass incarceration, ending homelessness, harm reduction, and mental health as a survivor of said broken systems. Felix is an advocate for the community at large. He has released a one-chap book entitled Savage Garden, Concrete Jungle, which I'm very excited to read after this. And it's a chapbook to remember me by. And it's soon to self-publish his first collection of poetry titled You Hold Space, You Have Value, You Are Loved. Felix's work touches the universal themes of redemption, transformation, restoration, and self-love, as well as self-acceptance, and is sure to captivate. Thank you, Felix, for joining us. And then another wonderful CCIT NYC colleague, I would like to introduce Peggy Herrera. Peggy is the mother of a son who struggles with mental health concerns, an advocate for mental health treatment. She is a member leader of Freedom Agenda, a program of the Urban Justice Center, and Center for Community Alternatives. Peggy has been a leader in the Close Rikers campaign and a counselor for justice-involved youth. Her journey to justice has been shared widely and has appeared in various publications, including a published op-ed in City Limits. And that op-ed was titled, NYC's Budget Does Not Make Policing Safer for Those with Mental Illness. And she also has another op-ed in the Daily News titled, Get Safety Officers Out of Schools. She was recently nominated as Politico's biggest winner for the week and that week was of March 4th, 2020. Her journey has also been featured in the Queen's Eagle, Patch, and on television networks such as Pix 11, Telemundo, and Univision. Peggy has a lifetime commitment to intersectional criminal justice reform and seeks no more than to work towards true equity for vulnerable populations. Thank you, Peggy. And then I'm going to introduce Anne-Marie Lewison. Hi, Anne-Marie. Anne-Marie Lewison is the Chief Strategic Initiatives Officer at the Center for Alternative Sentencing and Employment Services, otherwise known as CASES. Ms. Lewison joined CASES in 1999 as a co-founder of the Nathaniel Project. The award-winning Nathaniel Project was launched in 2000 as the first alternative to incarceration, or ATI, program in Manhattan for adults with serious mental illnesses convicted of felony crimes. Ms. Lewison has developed ATI programs that operate in arraignments, or first court appearance, as well as the criminal and Supreme Courts, and facilitated the introduction of our 2003 Evidence-Based Assertive Community Treatment, or ACT, as an ATI program. CASES is proud to operate effective mobile and clinic treatment, pre-trial supervision, ATIs, and reentry services for youth and adults. Thank you for joining us, Anne-Marie. And so let's just dive right in. I'm so happy to have you all today. We really want to focus on this first segment about crisis response, policing, and the criminalization of mental illness. So the issue is individuals with mental illness, as we're well aware, are incarcerated at far higher rates than the general public. We have over 50% of incarcerated persons on Rikers displaying at least some symptoms of mental illness. We want to know from the panelists, what is your analysis or viewpoint of why that's the case? And what can we be doing to address this disparity? I'm going to begin with Alex.
Thanks, Kimberly.
Oh, Alex, you're on mute. It's okay, it's the theme of this whole pandemic.
I was muted by the host. Here we go. Okay, so now that I'm unmuted. All right. So thank you, Kimberly. I'm so happy to be on with this amazing panel of folks who are really doing this work on the ground every day in a really difficult environment. So I'll just give a little bit of history about how I understand this. Basically, what we're dealing with here is the systematic long-term defunding of basic mental health services. And a lot of this begins with the closing down of state-run hospitals, asylums, locked facilities that were warehousing, in often horrible conditions, folks who had a variety of challenges. And the decision was made to close those places down, in part because of the human rights abuses that were occurring, but also because of the development of new generations of drugs that were able to provide some help for some people and the promise of more independent living. And the states said, and the federal government said, look, we're going to close these places down, but we're going to take the savings and put it into community-based services to support people in their efforts to live independently. But that support for independent living never really materialized. And this has left cities and individuals and families in a completely untenable situation, which is trying to manage with inadequate community-based services, inadequate access to high-quality insurance for many Americans. And then when a crisis happens, that falls to the criminal justice system as the backstop. The criminal legal system is not equipped to manage this problem. So what happens is that problems spiral out of control and then get labeled crime problems, disorder problems that end up pushing people into the criminal system. So I'll stop there and really interested to hear what the other panelists have to say.
Definitely. Thank you so much, Alex. And also, we would just like for all participants to please mute themselves once entering the forum so that we could hear the panelists. I think that was a very good overview of what we're talking about here today. And I really want to hear from a family perspective, you know, why what we're seeing from families who have first lived hand experience with loved ones who have unfortunately had run-ins with the law instead of being faced with proper care. And for that, I think I'm going to call on Peggy, because I feel like you're well versed in this, and I really want to hear your viewpoint, and I'm sure audience members would like to know as well. I think you're on mute. Oh, I'll unmute you. Let's see if I can do that.
Okay. Yes, it was saying the host had to unmute me. So hello, everyone. And it's just so nice to be here and having this platform and being able to push for change. So my perspective on this is usually someone with mental health issues, concerns are criminalized because no one takes the time to find out what's going on with the person. They don't know what's triggering the person. They don't know where the behavior is coming from. They're just looking at someone misbehaving or just in the middle of a crisis and acting out, and they think that this person is a criminal now. And for myself, having a son who suffers from mental health concerns, I know that very well. He's always been criminalized, and no one has ever taken the time to find out what's going on with him. And if you're not aware of my story, in 2019, I was arrested after calling for help for my son, who was in a crisis. He wasn't aggressive, as he's never aggressive during a crisis. If anything, that he's more harm to himself than he would be to anyone else, and just needed a chance to talk. But in those times, he's often criminalized. And, you know, as his advocate, you know, I've been his biggest help. But if it weren't for that, you know, 99% of those that sit on Rikers Island are sitting there, have a mental health concern. And it's because their behavior has provoked a police response. And they're not getting treatment in there. They're not getting any of the services they need. So they just sit there and they're labeled as a criminal. And so I think that they need to remove police from a crisis response, because they don't know they don't have the compassion, they don't have the training, they don't have what they need to actually give somebody the help they need at that moment during a crisis.
Thank you. And thank you, Peggy, for sharing your voice and your story. I really want to validate you and know that, yeah, we really need to be doing more. And I know that we have, I myself identify as a peer, and I know that some of my fellow panelists do as well. So I wanted to hear, you know, what's going on in the peer perspective. Why do you think that there's such a high rate and over incarceration of folks living with mental health illness, especially in this city? Felix, do you have what is your viewpoint on this?
So as a formerly incarcerated individual, I spent time on Rikers Island. So I know firsthand how the mental health system, how the correctional system failed me myself. I should have, at that point in time, mental health courts weren't available. So I should have gotten treatment and not incarceration. What would have benefited me was treatment and not incarceration. I think that when we talk about the amount of people that have mental health, experience mental health challenges on Rikers Island and in the carceral system, we have to look at the societal failures that create this sort of round robin, sort of like hamster wheel that doesn't allow people to get resources and community. I think that the transition from incarceration, detainment, to back to society, we have to start looking at bringing resources to people to prevent them from losing everything when they are incarcerated, coming back into, you know, shelters, hospitals, the street, and then that just keeps going and going and going. And you know, as someone who has experienced you know, the police response to mental health crisis myself, I want to say that as someone who is formerly incarcerated, that kind of law enforcement response to what is in fact a medical emergency should not be warranted. There's no reason why there are multiple police officers, some black gloves, some riot shields already. I don't understand why. I'm a pacifist, and also I can de-escalate. There's no reason why I talk for hours with the same police officers and they don't want to leave or they don't want to do anything except take me to the hospital. And it's just the lack of communication, the lack of mediation that you know, that isn't utilized, you know. And then just the societal failures of the mental health system and how all those systems intersect, you know, homelessness, you know, education, the prison, school to prison pipeline, and it's just a lot. So when we talk about the failings of the mental health system and how that intersects with the carceral system, we have to start looking at how resources are being earmarked in community, and start looking at how we can address mental health as a spectrum, as opposed to just a brief intervention, medication, and just leaving people to have the same kind of situational stressors in place without addressing those. So thank you.
Thank you, Felix. Definitely. So I value your perspective, and I really want to hear now that you mentioned some about Rikers and some meta level changes that need to occur in order for peers to really have the resources that they need. And lucky for us, we have two more panelists that really have, you know, firsthand experience. We have Solomon from the PA's office that has more intel on what our inner workings of our government really are working towards in sort of addressing this issue. And we have Anne-Marie, who has proposed alternatives to incarceration in her line of work. So I'm going to actually pivot to Solomon, and really, why do you think that we have these high rates of folks with mental illness? And earlier I mentioned 50% of incarcerated individuals on Rikers, but the literature really says that nationwide up to 60% of folks could have a diagnosable mental illness within our prison and jail system. So we really want to be getting to the root causes of why that is the case. And Solomon, I know you do some work around this, so please do tell us your viewpoint.
Yeah, thank you for having me. And again, shout out to all the panelists who bring the information. And I think the root causes is the right words to really talk about this issue when it comes to why half the people who are incarcerated on Rikers are there and not someplace else. And I think Alex touched on one of the keys to those roots, which is the lack of access to psychiatric facilities. Even more so during COVID, we saw hospitals turning over their psychiatric beds for intake of COVID patients. And, you know, while that's, you know, a response to a global emergency, we also have to analyze how those reprioritizations impact our community and also reflect what we feel about people who have mental health illnesses, which I think is stigma is a huge part of the problem. But another part, along with the lack of access to hospital care, is the lack of access to housing. and appropriate support services for those who are suffering from mental illness while experiencing homelessness. We have a statistic from the Department of Homeless Services that 40% of single adults in city shelters are suffering from mental illness. And during the pandemic, the closure of the subways and the over-policing and changes in MTA emergency rules prevented a lot of people who were living street homeless in a way that was working for them, found themselves being swept into situations where they could no longer hold the stability, the frail stability that was already in place. And this is further exacerbated by street sweeps that were breaking up homeless encampments where people are striving to survive. And one of the reasons why people stay on the street is because if you go into a congregate setting, you can't bring your people, you can't bring your pets, you can't bring your property, things that actually support your mental health. And, you know, we don't look at these things intersectionally, and that's a huge root. And another, I would say, third root would be the way we speak about drug user health and the intersection of mental health and substance use treatment. We saw many people during the pandemic who were subject to experiencing closed methadone clinics, people who were living in shelters who couldn't get access to their medically assisted treatment, people who were incarcerated, who could not receive the medicine that they need, that is prescribed to them. And this is just a basic need meeting that hasn't been taking place, exacerbated by the pandemic, but has always been a standard when it comes to people who are incarcerated because of the low staffing levels that prevent officers from being able to deliver the basic minimums to human beings. So we also want to note that 90% of the people who are incarcerated on Rikers are there without a conviction. They're being held pre-trial. So imagine how that creates mental health problems for someone who was not guilty of a crime, but yet is being punished for something as if with no support. So the way we structure our criminal justice system, the way the peripheral services around poverty, it's really the criminalization of poverty that's extending into what's making our system not function right. And we reflect that the way we don't prioritize mental health. So thank you.
No, thank you. And thank you for sharing that perspective. You mentioned something that struck me is the number of folks waiting pre-trial. And I know Anne-Marie has, you know, is more well-versed in how our court systems could be used to promote diversion and to really promote health recovery and the road to peer recovery. So Anne-Marie, tell us about your work a little bit at Cases and also why you think that this is such a great problem.
Thanks, Kimberly, and thank you for allowing me to be here and share my thoughts. I did want to start with the notion of the criminalization of mental illness, particularly in New York City, tracks criminalization in general. And I think it's important that we consider that criminalization in general sweeps in, as Solomon described, poor people, people that are homeless, and people that are overwhelmingly Black, Latinx, and people of color. And that is the experience of criminalization. And so one of the things that my experience at Cases has taught me in the 21 years that I've been working in alternatives to incarceration for people with mental illnesses is that in addition to mental illnesses, there's homelessness, you know, there's unemployment, there are all of these other factors that are intersecting. And to be honest, there's racism. You know, when we're specifically talking about New York City, I've been to Idaho to see interventions for people with serious mental illness. I've been to Tennessee, I've been to Florida. And, you know, in communities that are overwhelmingly white, that we see the experience of the criminalization of people with mental illness still tracks poverty, tracks homelessness, tracks unemployment. So there's a degree to which, you know, we in this country are very comfortable with the criminal justice system being the solver of social problems. And it's just a no starter. It's just a no starter. And so Truth be told, I have worked in alternatives to incarceration for people with serious mental illnesses for 21 years. They are not the solution. They are doing what they're supposed to do, which is they are preventing people, whether they're young people, whether they're people with mental illness, from not going to jail and not going to prison. And that is critical. That is really critical. But the pipeline continues. In New York City, even at smaller numbers, the pipeline continues. So it means that we're really not solving the problem, which I do believe when we think about mental illness and people with mental illness is the value we give to people with mental illnesses. I think that is central to the lack of real progress that we have made. And we really do need to think about transformation. And so we've added programs at Cases. I'm proud of the work. We have wonderful staff who are just working every day tirelessly to work with individual clients to make progress. But it's not the solution. And, and I can come back to that as we move through the evening. Thank you.
No, and thank you for all the hard work you're doing towards that transformation. This is definitely what the goal of this panel is to educate on transformation. And so I'm just going to dive right in on what could be a potential transformation. We hear folks speaking and advocates on the ground really calling for closing down Rikers. And so this question could really be for anybody. Do you believe that closing Rikers and moving towards decarceration in general is a necessary step towards decriminalizing mental illness in our city? Tell me a little bit about that. Who would like to take that on? Felix.
So I actually sit on the City Council Commission for Community Reinvestment and the closure of Rikers Island. So I'm one of the formerly incarcerated folks that is part of the grander coalition, which is looking to bring from the closure of Rikers Island, the 200, 300 millions of dollars from the closure of Rikers Island into the communities to further decarcerate New York City. So with that being said, when there's supposed to be 10 neighborhoods to be looked at for those funds, we have to really start addressing poverty from the ground floor up to actually make that impact. When the entry points to mental health services can sometimes actually be a hospital or prison, we should actually be assuring that everyone has insurance, everyone has access to culturally competent care. We should actually be making sure that there are violence interruption programs. We should be looking at having employment services being made available. We should be having more vocational trainings. As a whole, we need to look at why people fail, why society is failing people, and we are stockpiling, warehousing people on Rikers Island while they are actually in need of being brought back to life. I think that when people enter the carceral system, it's hard to get out of that. Without the resources in place, you kind of just, it's a hamster wheel, just kind of spin in place. And without having the monies drawn to these systemic failings, nothing will be able to change. And when we talk about decarcerating Rikers Island, we talk about decarcerating the largest mental health facility in, I believe, the United States, I believe. And then we have to look at why so many people are in Rikers Island with mental illnesses. Are the mental illnesses happening beforehand or actually while at Rikers? And that's something that we have to really address, is that people need to be able to have these conversations in public about where can I go for help? I don't know what to do with my emotions. Can someone guide me through them? Or, just having actually access points in community to get to a better, have better mental clarity and just feel a part of community itself. I think that when you isolate people, when you separate people from family support systems, loved ones, their job opportunities and so forth, you kind of create this whole microcosm within a microcosm of New York City. And when we talk about decarceration, we need to talk about like bringing people back to life, bringing people back into society to actually have an opportunity to change. And we need to start looking at getting help for those people that are incarcerated so that they can come back to a society that welcomes them.
Yeah.
Thank you.
Yeah, you know what? All panelists can unmute themselves. If you have any issue unmuting, let me know. Because I really want us to just jump in here. I really want to hear different perspectives on this. I'm sure I'm very invested in learning more from each of you, and I'm sure the audience members are as well. Peggy, I feel like
Yes.
you had something to add.
I do. So we know that, first of all, Freedom Agenda is a coalition that's working on doing a treatment, not jail. So I believe in treatment. I think everyone who stands before a judge needs to be evaluated. We don't just get to this place. There's a reason we're in the place that we're at. So if you're standing before a judge, you've committed a crime or you haven't committed a crime, you're there, something got you there. That didn't happen yesterday, didn't start today. Something happened and we need to start evaluating people. We need to start asking the questions and finding out what happened so that we can learn to treat people, so that we can get people better. People that are being put in jail, they're not going back to their communities where they're saying it's so unsafe. They're coming back home to my community. My son will come back to my home. And if you don't make him better, it is me who goes through everything. It is me that gets abused. And so if we're gonna help someone, we need to help not only the person, but the family, okay? In times of crisis, I need to have a place to go for the night and not sleep in my car, but have services available for both me and my son. Having Rikers open, first of all, we know that right now, Rikers Island is the biggest mental health center. That's where they house everyone with mental health issues. We can't continue to rely on Rikers as a mental health center. We need to get resources, okay? The lack of resources has always been a barrier to getting my son what he needs, and for people that are outside homeless with no services are on Rikers Island, okay? Getting people treatment and not putting them in jail, it's diverting them. It's diverting them to getting them what they need, okay? We want to also take the power away from district attorneys that make those decisions to put someone in jail instead of getting them treatment when even when they don't have a diagnosis yet, they need to be evaluated. But when they have a diagnosis, you need to stop making them take a guilty plea and making sure that they get the treatment that they need. I don't know if anyone's aware, for example, there are 47 new mental health court participants in New York City in all of 2019, including just 38 on a felony, and just 10 in 2020, just 8 on a felony. So the main goal is to prevent people with mental health needs from being arrested and brought into a court, being brought into a court in the first place. But if they do end up there, we can't have DAs as the gatekeeper. Yes or no? So we need to get rid of Rikers. It's not a treatment center.
We don't know where it is, sir. You're gonna have to live without it tonight. Okay, so
If I could just ask the folks who are in the audience to mute, please. I believe it's Nicole Russell.
You might
yes.
be able to mute her by going to the participant list and hitting mute.
Yes.
I just wanted to say that, one of the mistakes our political leaders keep making is that they're so committed to the propping up the criminal legal system that what they say is, oh, well, since Rikers is this huge repository of folks with mental health problems, then we need to create more mental health services at Rikers and create more mental health courts and create more criminal justice-based diversion programs. So that what we see is putting more resources into the criminal legal system, but that system is the worst possible system for delivering help to people. It is inefficient and ineffective, and it's all rooted in this mindset of punishment, personal responsibility, consequences, and it's entirely reactive. It waits until someone is in a desperate crisis, and then it says, well, you know, we'll give you some help. And if you don't do it just the way we say, then we're going to put you in Rikers Island. We have to break this whole mindset that this is an appropriate place to deal with people's problems. We have to quit thinking in terms of mental health courts and diversion programs and actually give people resources to live independently, healthy, and with dignity.
Wow, I can get behind that. Definitely. Thank you, Alex. Felix, you have something to add?
Yes, as someone who experienced the mental health system while incarcerated, I want to say that you know, it failed me completely. I was misdiagnosed, and as a result of that, I went through the through just the insanity of the mental health system, being treated as though I was just a number or just a body or just a case on someone's caseload. And I think that for me at that point in time, this is me without having experienced the alternatives to incarceration, which was a mental health court. So, you know, seeing how mental health court is helping, but it's only a Band-Aid. We really need to look at like just community. What are we doing in the community to actually bring awareness and actually bring that change about? Everyone should be, at the very least, should be going about trying to do mental health first aid at the very least, just as a civic duty to try and take care of one another in community. I think that when we look at to get treatment in a carceral setting, that implies that that treatment is supposedly valid. But if it's not valid, then what are you doing? You're actually just causing harm. And that comes with actually having trauma-informed care and actually having peers that can actually help you and mentor you through the process of being in unforeseen circumstances. So we need more learned individuals. We need more peers. We need more opportunities. And for me, incarceration, detainment on Rikers Island did not help me one bit. I have PTSD from Rikers Island, so I could have done without the violence. So
Thank you, Felix. Thank you for sharing your story. And I am so sorry our system, fails peers on a daily basis. And sorry to hear that Rikers is, I'm just shocked, and I'm sure members from the audience are also just shocked to hear how Rikers is the #1 mental health provider in our city. A lot of you have mentioned this term of investing in our community and funding for the preventive services so that folks don't even have to go and appear before a mental health court or be incarcerated in other senses. You may have heard that the current mayor has proposed $112 million as part of the city's mental health recovery budget to implement a citywide mental health crisis response next fiscal year, so FY22. However, we know that, we have our current administration, they're here for the next 6 months of FY22, but come January, we're gonna have a whole new leadership. We're gonna have a new mayor, we're gonna have new city council members, a new comptroller. And so I really feel like we should utilize this time right now to talk about, what is your take on how the city government could best utilize this $112 million in order to ensure an optimal crisis response system? I know that there are some proposals out there currently by the administration, but in other words, we really want to know from you all with direct lived experience and direct professional experience, what should an effective citywide response system to mental health crises calls look like in New York City? Peggy, I see that you want to jump in. Let's go. Tell me.
We need our own number. We need our own number. They should never respond. They shouldn't even get the call. They shouldn't even know about it. That's the way I feel. Okay. They have no compassion for our communities. Okay. And those of them that say that they have some compassion, you're silent. So as far as I'm concerned, silence is violence. You're with them. Okay. We need a whole new number. We need to remove police from all mental health crisis response. And we need to invest in meeting people's needs. You want safety in our communities? Provide housing. You want safety? Provide treatment. You want safety? Provide employment, quality treatment. Give people what they need. Make people feel safe. If people don't feel safe, this is what you're going to get. This is the response you're going to get. Making sure that people have the basic needs. You know, I am always inspired by Felix. You know, I've seen how far he's come, and, you know, and he's getting the things he needs. And I see how much he's grown from that. He's just a whole different person. And every time I see him, I'm so much more inspired because I know that it works. It works. You know, I love you, Felix. And, you know, we have to really challenge ourselves to think of how we can remove criminalization from all the spaces where people with mental health needs are experiencing it. We know there's not enough supportive housing. We know there's not enough jobs. There's not enough inpatient treatment. And for people who are in supportive housing or in a hospital and they act up, you know, we need to still remove police from that, because I know that I work in a facility and police were called when they shouldn't have been called. I witnessed with my eyes how that ended, and it wasn't good. Police do not need to show up during a crisis when they come here. And I'll end with this quickly. I called one day because my son really had a medical issue, right? That sounds kind of weird because mental health is a medical issue, but I was trying to explain to them, no, this is a medical issue, when they were both the same. And they were like, well, does he have any anxiety? I'm like, no, we're not calling about that. We're calling about medical. We need medical. And it was the strangest thing trying to explain to them and trying to separate the two when I knew the two were the same. I know the two belong to an EMS and not to a police. And when they came here, they made my son feel really uncomfortable, you know, and I had to make them aware of that, you know, because you have a gun, because you have a uniform, my son doesn't feel safe. I don't feel safe when you come in my house and you put the lock on the door, even though I'm telling you, he's literally hurting. He has a medical issue. And it really made me mad because I don't know why they separate the two. Mental health is a medical issue, and and if someone gets sick, it's a medical issue. Either one is a medical issue. We should not have to feel like we are being criminalized every time they come to our door. We should feel safe, and a peer, a social worker, those people make us feel safe. And they cannot use that they don't feel safe, that they're aggressive, because we know that 99% of mental health calls are not aggressive. They're usually more a danger to themselves. When they see a uniform and a gun, that triggers them. That makes them feel unsafe. And that is why people try to hurt themselves in the presence of police. So we need to remove them, and we need to provide people what they need in order for them to feel safe. And when a person feels safe, and when we give them what they need, we show them that they matter. That's how we need to, that's a start.
Thank you, Peggy. And so you mentioned at first, you started off talking about how we need our own number. And I'm sure it's something that's recognizable, something that right away you're like, mental health crisis, I can dial. And so I just want to make the audience aware that there is a federal mandate that by July 16, 2022, all 50 states have to implement a 988 number. So that's 988, not 911. I see some folks in the chat have mentioned that as well. For folks to be able to call during a mental health crisis and be met with an appropriate mental health response. I do want to hear a little bit more, you know, from Solomon. I know the PA's office has been working on this, and we wanted to get your take on the role of peers, as Peggy mentioned, and also this notion, there has been notion of co-response models with police, you know, joint response with police and a mental health crisis team. And what is your take on that?
Yeah, last year our office actually released a plan, which I'm gonna put into the chat so folks can see, around redefining public safety. And in that plan, we call for a non-police response unit that would consist of a clinician, a social worker, and a mental health peer. And this is in contrast to the mayor's current plan to have a team consisting of 2 EMTs and a social worker available 16 hours a day. And as Peggy was mentioning, we also have been championing a legislation that would cause mental health calls to be diverted by using this 988 number, as you mentioned, Kimberly, that it will be nationally instituted. And so it makes sense for those who are seeking help for something related to suicide would also be using the same number to address other mental health issues. We also need more support and connection centers that are tied with more outreach that ensures people who are struggling with mental health in New York can actually get the help we deserve. We're worried about the fact that there's so many New Yorkers who are assisted by one that's in East Harlem, while there's another one in the Bronx that's still not open. And this is after years of promises that these things would be available. And they need to be centered in places that we are experiencing the highest number of mental health calls. We are calling for 20 million for 4 new support and connection centers and $7 million for 2 new respite centers in the city budget. And we know that the plan can do more than the $112 million pilot to make an effective citywide response system. And we need to get our system right instead of rushing to plans that leave us with more questions than answers. And so our office is concerned about the rollout of this program, particularly that only 16 EMTs have reportedly signed up to join the program. And so we need to make sure that people are experiencing a crisis cultural competence among mobile crisis teams. And this existing plan also doesn't really address this question. So community outreach and public information must be part of any plan for a crisis response system. And this is central component of our plan, how we put things together. And so I'm also going to put in the chat a report that was released around mental health crisis response in 2019, and just note, I guess we'll talk about later on pieces of legislation that are connected to some of the findings in the report, which were worked on with community partners such as CCIT and Communities United for Police Reform and other folks who are involved in this issue.
Thanks, Solomon. And so you mentioned something that really struck my attention, because I know there is some division on, you know, who should make up these teams, right? There's some division. We have the city currently, the mayor's office with the social workers and the EMTs. And then we have what you're proposing that would be more inclusive of you mentioned social worker, EMT, and peer, I believe, and a clinician maybe. And then we do know that there are other perspectives as well, that there shouldn't be clinicians for the most part. There should be EMTs and trained peers, something sort of similar to the CAHOOTS model. So I didn't know if any of the folks on the call really have any viewpoint as to that, or why do people propose that model? Felix?
That's just the model that makes the most sense. We're talking about having someone with lived experience and actually having a medical professional there to address any kind of a medical emergency that might be happening. And you know, I'm not trying to demonize NYPD or whatnot, but we need people that are relatable, compassionate, that actually understand what is happening. We need people that are trained in mental health. We need people that are trained in medical to give medical attention. We need people who are able to de-escalate and to de-escalate someone who is in mental health crisis. That is something that unfortunately I myself have experienced, trying to de-escalate my own wellness checks. And that didn't work out too well, as no matter how passive I talked or tried to talk things through, there was no, once the police are called, you're coming with me, you're going to the hospital, that's it. You're either coming in handcuffed, you're either coming quietly without any kind of objection, or you're coming in handcuffs. And that's the extent of the interaction that I have with NYPD in a wellness check. And to be in the throes of crisis and have to de-escalate, to have to, you know, to work around, you know, being as passive as a mouse to just being, you know, going limp body-wise or whatever the case may be. I think people, when they realize what a person with mental health, who's experiencing mental health crisis goes through to get help in that moment, people will actually understand the fear, the unknowing fear of what can happen next. And we need to remove that from these encounters. We need to actually have compassion. We actually need to have dignity restored, not removed. And I think that in these last few years, things have been changing. Yes, they have been, but slowly. And I think that having a peer and an EMT would be amazing. I think having these medical emergency response times being lessened would be amazing. I think just addressing poverty as a public health crisis, as its own mental illness, probably even so, would actually help to change the ecosystems in place.
So is there any, do any panelists have any concerns with social workers or clinicians by themselves showing up without peers?
Yeah, I think that's really the issue here, right? The mayor's plan is EMT centered and does not include peers. And the CAHOOTS model, other models are trying to do something that includes peers. And here's the deal, right? In some ways we say, well, EMT, that's a lot better than sending armed police. And that's certainly true. But we're stuck in a bad dynamic here, which is that this $112 million is not going to expand the availability of high quality mental health services.
Mm.
And so these new teams are going to be facing much of the same dilemma that police and EMTs face now, which is very few good options. They can take someone to an emergency room, sometimes against their will. They can drive them into the criminal legal system, or they can try to come up with some temporary informal resolution out in the field. But none of these connect someone to real services. And I think a lot of people, when they see the EMTs show up with someone else in some official capacity, they're like, that starts to look like forced hospitalization to them. And that runs the risk of an escalation similar to what you might see when the police show up. When we look at the models that exist in Colorado, in Oregon, that try to rely less on that medicalized model, we see that forced emergency room situations, criminal legal interventions fall dramatically, and almost never are police needed. In the first 6 months of the new system in Denver, the unit did not ask for police backup a single time in 6 months. And in Oregon, where they handle a huge volume of calls, less than 0.5% of the calls ever result in any kind of request for police assistance, which is usually not because of some extreme violence. So let's get a peer-centered strategy in place, but let's also significantly increase the availability of options for these teams. This is the problem with like a co-response model that includes police as well. They don't work if there's no increase in actual community-based services.
Thank you, Alex. And you mentioned that we at NAMI, we know that ensuring the safety and well-being of those with mental illness is more than just crisis response. We've been talking a lot of crisis response. Alex noted right there that it's more than that. We need to have the services on the ground in order to make sure that we have a fully funded and capable mental health care system. And this means ensuring wraparound or all-inclusive care or other resources that help prevent a crisis before one happens. So this last question, and I know Anne-Marie has a lot of experience with talking about wraparound services in our city. This last question before we move to the chat, I really want us to talk about, what services or programs or even legislation should the city prioritize aside from crisis response teams in order for our communities to fully thrive, pun not intended, to flourish?
It's a great question and an important question, and particularly during this time of the pandemic, where we have seen significant increases in demand and requests for mental health treatment. At Cases, we run an outpatient mental health clinic in Central Harlem. I think our clinic director is describing a 300 or 400% increase in people presenting for services, which really goes to the point that Alex and Peggy and Felix are making, that and Solomon, that the one-off going in and responding to the crisis will not work unless there is something to hold following the crisis. I was remembering that New York City Department of Health and Mental Hygiene, maybe about sort of 9 years ago, had tested actually a year-long mobile crisis model that included a peer and intentional peer support. So, a mobile crisis providing services for 1 year, which their data showed had really good outcomes, but did not continue. I believe maybe VNS tried to continue the model. So even when we have tried new things, we have not kept them because of the value we put on. And this was a model, Peggy, that involved the family. It was all about, you're going into a home, so the clients are the person in crisis and the family. And the team, which included a peer, continued to deliver those services for 1 year. And so I think that, it's really important. We've talked about housing. I think we have to rethink our outpatient mental health clinic model. We have to think about the state rates for those services. I know that years ago I went to a conference and there was someone from San Francisco who was describing an outpatient clinic that she ran, and this clinic was open from 5 in the afternoon to 7 in the morning. It wasn't open from 9 to 5. And so I think we really have to sort of think about, what is the delivery of treatment? What does that look like? What is the delivery of rehabilitation? What is the delivery of friendship for people that are isolated? All of these things are critical when we think about crisis, because to know that someone is in crisis and they can walk down the block and they can go into an outpatient mental health clinic and they can be served rather than informed, hi, we can have an appointment for you in 6 weeks. That's not appropriate. That's not humane. So we really have to think about investments. Peggy has said this, we have to invest in community in multiple ways, including in how we think about treatment. And we know that we use Medicaid, that's very critical, but we do have to re-envision treatment. What does it really look like? What is the notion of treatment? Is it just psychotherapy? Is it just medication? Is it actually employment-based? Is it friendship? All of these things are required when we think about the notion of people engaging in their own pathway to recovery, which is what we want. Like, that pathway to recovery is gonna be sort of central. And that's why peers have to be, people with lived experience have to be centered around this. This is just really critical for us to think about. People who have walked before in that path know how to navigate, know the ups and downs. And so that's really why we really do need to center people with lived experience in our response. I'm a professional, I know nothing. Because I'm a professional, I'm coming at it from a professional landscape. It's just really critical that we center people who lived experience and the families as we think about the solution, which really goes to who's at the table, who has the power, who is really envisioning what we mean by mental health in our city and in our state.
Thank you, Anne-Marie. As you're talking, I'm just like hearing you. I'm like, wow, I'm sure my therapist, there's so many times she wishes I had a crisis between 9 to 5, but it just doesn't happen that way, right? It just doesn't. The crisis always comes at Sunday at 11 p.m. when my poor therapist is probably asleep. So I really hear you there. I really hear you, and the need for more peers. And so, Peggy, yeah,
I
let
have
us know.
to say something. First,
Go
I
ahead.
want to say thank you to Anne Marie for saying that. Like, I'm a professional. You know, we need people with lived experience going out. And just like what Alex said, I love what he said, but the Cahoots program in Oregon, it's working. It works. You know what I mean? The STAR program, which is a fairly new program, it's working. And here in New York, we still have people dying. And we know that 18% of Black and brown people are more likely to be killed during a police encounter. We need to do better. We need to do much better. And my feelings exactly, my thoughts exactly on that. This is something I've been pushing. Having a son, being a mother of a son who has these concerns, these mental health concerns. A phone call a week with a counselor, a once a month psychiatrist appointment, that's not working. I'm living it. That doesn't work. That's not treatment for me. Treatment is sometimes, as for him, he needs to be in an inpatient somewhere, or even a very intense outpatient where it offers him coping skills, things that I can't teach him as his mother. He needs coping skills. He needs to learn a trade while he's there. He needs to learn different things. He needs to be educated while he's there. And we need to work together. The whole family needs to be involved in this. It can't just be him, and it can't just be a one phone call a week. That, by the way, he's supposedly getting now, and sometimes they forget to call. How good is that? When we know that people with mental health issues go through their own things on their own, you know? And so we need to do better in how we provide treatment. So if you're gonna give us funding, we need more treatment. And just like I say to the judges, I want the same treatment you're getting for your kids. Because I did my own little study. I drove around. I used to drive around at night. And if you go to like Astoria, Queens, I don't see anybody at night dealing with mental health issues, sleeping on the street, homeless, screaming, or any of that. I don't see it in areas of Manhattan, in the Midtown Manhattan. But I do see it when I walk up my block. I see it on Hillside Avenue in the Jamaica area. Why? Because it's our communities that are affected the most. So you take a person that's homeless and is acting out, you arrest him because you say, we must take you in for treatment. But then you take him, and that's already criminalizing him, because now you're putting handcuffs on him because he doesn't want to go. Now you traumatize him more, you criminalized him. He has no home, he has no food, he's poor, he's Black, he's brown. What else is against him? How are you helping him? So you take him in, he sleeps there for a few hours, and you let him go without helping him process all the trauma that he's going through. We need real services. We don't just need a once a week counseling and a once a month psychiatry and just medication. We need intense treatment. We need them to deal with the real issues and ask the real questions and bring healing to our communities and our families.
Thank you, Peggy. Thank you for sharing that perspective. Solomon, are you about to get policy wonky with me? Let's talk
Yeah,
policies. What legislation? How can we codify this?
I definitely think that part of our response and solutions has to do with, community-led, directly impacted, focus solutions that are involving people who are actually suffering from the most vulnerable conditions. In addition to the legislation I mentioned, which was around the shifting the 911 to 988 for mental health calls, is Intro 2222. And this would be the new way that folks would be able to access resources for mental health when they would seek an emergency. But there's another piece about over-policing that we're actually not discussing at all during this conversation, which is at the root of a lot of the ways that people get engaged in the justice system from the outset. And there's also some legislation that we have been developing around surveillance technology and use of force tools. We have 3 bills in City Council. One right now, Intro 2013, would limit the police use of electrical weapons and provide data on the use of said weapons. These electrical weapons do not have strict guidelines around their use. And a 2019 CCRB report indicated that tasers are disproportionately used on people experiencing mental health crises, as well as Black and brown New Yorkers in general. And folks can recall Kowalski Trawick, who was fatally shot after being tased, and shot after the response to being tased. So also by officers who were trained in crisis intervention days earlier. So, if we don't name this type of issue and this permission we have to use force on people who we consider, having a mental health crisis, we're gonna find our way to not creating the solution that we need. But in addition to that, we need to elevate the way that we have access to when things go wrong. So we have Intro 1989 that would provide the Office of the Inspector General and the Department of Records to access body-worn camera footage within 5 days of the recording. This makes it easier for us to access footage that's often difficult to obtain and delays our ability to formulate demands that are timely. We also have Intro 0817, which would prohibit any unauthorized surveillance by a GPS system or any similar technology. Any tracking of a person's motor vehicle without the person's consent would be a misdemeanor. And this prohibits people from being targeted as individuals who would cause harm. And there also should be clear guidelines when youth interact with officers and procedure for youth when they are interrogated. We don't talk about youth with mental health crises enough engaging with officers, and our office has its own legislation, Intro 2012, that requires the NYPD to issue a quarterly report on interrogation of minors with data that includes the number of times a person was interrogated, the demographic profile of the minor, and whether a parent or legal guardian was informed of the arrest before the interrogation. We've also held town halls around banning facial recognition technology that's used by NYPD and other institutions that mainly monitor Black and brown communities. So these forms of trying to keep track is what reinforces stigma. And these are the types of tools that we shouldn't be permitting the use of, and should be trying to curtail the way that they're disproportionately used against people who have mental illness. So there's tangible things that we can do on the policy side that, when joined together with the work of directly impacted people who are out on the front lines, can really cause transformation. And that's what we hope to happen over this next budget cycle.
Thank you for sharing. I know panelists are eager to jump in, but we're going to now pivot to the Q&A. Solomon, thank you for sharing all that policy. You know, we're friends here, but we need that co-response language out of Intro 2222. So we still need our legislators to make sure that if we're taking a step in the right direction, we're going to go all the way. We're going to go all the way. And we want to see those mental health response teams out there, make sure that they're peer-led, but also that it's clearly defined when the police can or cannot show up.
To clarify, Intro 2222 is not addressing the co-response.
Okay, it's the 9881.
It's the 9881 number.
Okay, just making sure.
Piece of legislation you're referring to.
Just making sure, friend. Just making sure. Okay, thank you. Policy perspective, peer perspective, family perspective. Let's hear what our audience members' perspectives are. So I have a good question out here. What is suggested for the public to bring light to incarceration of the mental health crisis? There is a mayoral race coming up in June. How do we get our elected officials or our candidates to address these issues once they're elected? Anyone? Any of the panelists? I'm going to insert myself. So we do have a mayoral race coming up. I have been putting in the chat some draft tweets that we could really be putting out there to make sure that there's some momentum, at least on the social media side. I'm going to put in 2 more. One of them is actually geared completely towards our top 8 or 9 candidates for mayor. And we really do need to press them. We need to be talking when they want to talk to us, when they're knocking on our doors, when they're calling us. We're in the middle of I pick up my niece and somebody's like, you can vote for me. I'm like, let me tell you something. What are you going to do about mental health? Tell me, what's your platform? Are you going to include peers? Are you really going to set the stage when you come in? Are you going to continue these pilots that our current leadership is implementing right now, or are you going to change the system up? Because what we're doing right now isn't working. And even what we're proposing right now, Alex mentioned this, mentioned the research with Cahoots and other models in other places. There's evidence. There's hard numbers that nobody's getting hurt. Police are not getting called. So we really need to make sure whoever you are voting for really has a clear stance on these issues, and you can press them on social media. You can show up to the events where they're advertising or they're trying to sway you. We really need to make sure our voice is heard. And once they get elected, then you're their constituent. And here at NAMI-NYC, if you go to our advocacy page and you scroll all the way to the bottom, we have an ambassador program that really trains folks on how to craft your story, your unique lived experience for legislative change. And really, we connect you with your city council member, your assembly member, your state senator, and you get the opportunity to talk with your own voice on the bills that really could impact you and your family. So we need to be making sure that there's more programs like that, and that folks are really feeling comfortable to engage with their electeds on these issues. But I digress. Let me try another one. Please tell us. Oh, I love this. Please tell us, what can we family members do to help fight for funding and resources? Tell me, panel. Please tell us. Similar to what I was mentioning. Peggy, do you have any? You are such a voice, a powerhouse. Oh, Felix. Anyone? Oh,
I'll let Peggy go.
I'm gonna unmute you.
Go ahead, Felix, and then I'll go after you.
Okay, so first, I'm a consumer services, so I take part in self-direction, which is a self-directed care model of services through community access, which provides me some monies available to me every quarter to help me in navigating purchasing services and or items which are imperative for me to have to continue my mental health recovery journey. And it has helped me to see a life coach. It has helped me to get furniture. It has helped me to to get equipment for my apartment, some furniture, some appliances. It has allowed me to see therapists that I want to. It has allowed me to see a music therapist. It has allowed me, to work outside of the framework of what Medicaid normally allows. And I think that by extending these kind of services available to a broader audience, it would help people be able to just take care of themselves. I think that for me, my understanding is that there are about $3,000 to $4,000 available every quarter, and that those are monies that I'm able to use to actually help to facilitate any kind of recovery things that I want to do, such as go back to school for a couple of things, pay for some certifications, some licensure, some clothing and stuff like that. So I think by having that little bit of extra money available to me to help me along my journey to stay in recovery, that helps tremendously. I think that families having an extra bit of money available to them to help their child to be able to go into the therapy of their choice sooner rather than later would help tremendously. And extending more respite centers, and actually extending, bringing more monies to the CDPAP program to allow people to be taken care of by relatives and friends and known parties, so they can actually be able to heal on their own terms. I think that we need, if Medicaid is basically is the American Express card of mental illness, then we should actually be making sure that it works to our benefit and actually bringing services that are actually tangible, that actually have results, that actually aren't just people collecting payments and not providing services that work. So thank you.
Thank you, Felix. Peggy?
Can you repeat the question again? What is it that?
Yeah, the question is, what can family members be doing to help fight for funding and resources?
Oh, yeah, we need to be visiting their office and having actions and calling them and letting them hear our stories. You know, I often say that, you know, no one can know what I go through. You know, you can sit behind a desk and you can put policies together and you can put all these programs together. But if you don't know what I go through, how the many nights I've had to leave my house to go sleep in a car because my son is in a crisis and there's no help for us because I'm so afraid to call 911. If you don't know those things, you're quick to put a policy in place that doesn't work for me. You're quick to put some money together for what doesn't work for me. You need to know what we go through. And those people with lived experiences are the ones that can help us in our communities. So by us sharing our stories with them, making our voices heard, every platform that's out there, you taking advantage of the platforms to making sure that they hear us, making sure that they understand what we need as a people. They don't know what we need. They don't know what triggered my son when he has a crisis. They don't know. All they know is that they need mental health. What does that entail? You need to know, what does that entail? My crisis won't be the same as Felix's crisis. We all have different situations. So those that have lived it will understand us more. And that's what we need to make them know. Like we need them to hear us on that. You will never understand us if you haven't lived what we lived. And we need these resources. And we're the only ones that can tell them what we need. They can't tell me what I need because they don't live here. They don't know what I go through. I know what I need. I know what my community needs. And we definitely do not need police. So we need to just make that known to them through actions, through letters, through phone calls, as much as possible. I mean, going to their offices. Thanks.
Definitely. And that is the best way. You know, I always tell our ambassadors, part of the NAMI-NYC ambassador program, I tell them, nobody has a PhD in your lived experience. You have a PhD in you. You are the expert and you are also these legislators' boss. You know, they're there because of you. You voted them in and they're there to serve us, right? Obviously, you know, there's a lot of mechanisms in place, but if you don't speak and hold your voice or that space, if a family member or peer or anyone who really cares about these issues doesn't hold up that space, that seat stays empty, right? And I know that just for an example, right, quick example, there have been times where I'm advocating with a legislator for to pass long-acting injectable medication so that pharmacies can administer it. And this is some long-term medication that helps with adherence when folks have like for instance, a diagnosis of schizoaffective disorder, schizophrenia, or even folks who have substance use disorder. And when I was like explaining how like one of our ambassadors travels an hour during her lunch break to go get this medication at her community health center in a whole other borough, and then comes back and has like the stigma and this fear of how do I explain this to my job? And the legislator is like, well, why can't she just go to the pharmacy across the street? I'm like, that's what we're here talking about, sir. Like, this is the bill we're talking about. And so it's like, it's common sense, but if you're not bringing the visibility, then nobody's there to talk about these things. But let me keep going with these questions from the chat. So where would the checks and balances be? How could one opt for a respite center, a private or one-on-one doctor before hospitalization? Alex?
Yeah, I want to say something about that and a related issue in the chat, which is like, are we just, you know, mobilizing peer interventions for some big health conglomerate to make profits off of, right? So where's the accountability for that? And so I think it's really important that we talk about community empowerment here. Mm-hmm. That what we're doing is we're not just trying to build out a more compassionate, massive healthcare system. We're trying to take a completely different approach to health and well-being. that's rooted in communities, that's rooted in mutual aid, but that is also supported, where there are resources being put in. And that means we have to also mobilize government. But ideally, what we're talking about is mobilizing government resources in response to mobilize communities that are making clear what they think is best for them and the people they live and work with and love and care for. So I think it is very important that we ask these tough questions about accountability, who is making the decisions, who has power in these relationships.
Definitely. And, you know, as part of the steering committee of NYC, our proposal is really that this peer-led response, we could use this 112 million for a peer-led crisis response that really is housed with the community-based organizations already doing this great work, and they just need extra funding, extra sources to scale up and really meet the need, because there are great organizations. Our co-sponsored community access has a respite center that is great, and but you know, do they have the resources to meet the need? And we really want to see that whatever crisis response or extra investment in the city, in city resources for stabilization or supporting connection centers, you know, it's not just all housed within our city government, but also with people who have the expertise and the lived experience in these communities where they're from. And it's not the same when I walk by my community health center every day and they know my name, right? They see me on the commute home. Well, not now because I commute from the bedroom to here, but to the living room. But before, it's different when someone knows you in the community, and then when you step in for a crisis, you know, they already seem to know, you know, okay, where are this person's family members or where do they stay? But definitely, we have 5 minutes, so let me press on. So once you, okay, what do non-financial incentives look like? As in, once you bring folks into the work, how do you keep them there? How do you allow them to bring their experience into the work at the speed of trust rather than being mined and exploited for our knowledge? I think this question is referring to peers because, you know, as a woman of color and a peer, like there are instances where we know our communities are being tokenized as well. So, right. So how do we engage peers, bring folks into this work and really invest in them so that they are striving towards this? Anne-Marie, I feel like you have more experience in this.
Yeah, I was going to share, I know at Cases, as long as I've been at Cases, 21 years, we have had peer staff working in all of our programs, our alternatives to incarceration programs. And what I have learned in that experience, so I'm a manager, I'm a supervisor, I'm a, you know, part of an executive team, is that you have to believe in recovery if you are going to, you have to fundamentally believe in recovery if you are going to utilize peer staff. Otherwise, peer staff are used to be there in a token way. And so you have to fundamentally believe that people can recover from mental illnesses to effectively integrate peer staff, because you really want peer staff to be intentional in using their lived experience in the context of the relationship. And so that means that psychiatrists have to believe that people recover from mental illness, that there's more beyond the medical model of mental health treatment and recovery, that there are many pathways to recovery, of which, you know, the relationship is critical. That authentic sort of relationship is just critical. And so I think that is, you know, the beginning, that you have to fundamentally believe in recovery. And then, like anything else, you cannot have one person who is the peer in this large environment. There have to be multiple peers. There have to be peers at different levels, in different roles, to ensure that the culture, so you're not trying to assimilate peers into maybe a nonprofit culture or a hospital culture or mental health treatment, medical model culture. What you're trying to do is to integrate peer support for everybody, so that nurses, social workers, case managers, or everyone understands the role of lived experience as one of the most powerful tools in supporting, facilitating recovery, which means that I'm with everybody else. I believe it's time for 50, which means that this is an expertise that we should be paying peers at minimum $50,000 in New York City because it's an expertise. And so we find that peer staff are sometimes the lowest paid in the trajectory. And so we really do need to think about ways to elevate that, to ensure that we are not just, using people's expertise for the benefits, like reducing the things that people in the traditional mental health sphere may be concerned about, whether it's reduced emergency visits or reduced hospitalizations or reduced contact with our jail system. And so it's, again, like I think we really go back to, do we value people with mental illness? Do we value people with mental illness who are working in this space to support others to recover? And how much people get paid tells you if people are valued and what is valuable in any system, in any organization. And we have seen, with Medicaid and certification, that more and more people, like for years, community access have had Howie the Harp, and I know and have been connected to them for 20 years. And over time, we've seen more and more agencies looking for peer staff. But I think, and others in the city are really doing work to ensure that peers are not being exploited, that this is a profession. It's not just people doing goodwill work, that this is an expertise and a profession that we embrace and we think is really important. And so it's just critical that we value them in a way, and people are rewarded and paid in a way that communicates that we value them. And I think that is advocacy that really needs to happen, that we are saying to the health department, as you do contracts, like a peer specialist should be paid $75,000 because we value them, because they are bringing this level of expertise. And so that's what transformation is. It's imagining the sometimes impossible, but it's really critical that we do that. It's really critical that we continue to have more peer staff, because otherwise we're just not gonna change and realize what we are hoping to achieve, what the conversation this evening was about.
Yes, and you know what? That is honestly the best note to end on, because this is really all about centering peers and people with lived experience in order to help each other and help this community. We need to make sure our community is well supported and is valued for their work. And so you can't see this because you were so busy talking about transformation, but the chat is just loving it, Anne-Marie. We have some notable peers saying thank you. So I want to thank you. I want to thank all of our panelists, our lovely interpreters, Candace from out in California, and Andres, our Spanish interpreter. We want to thank Prop for being a main co-sponsor of this event, but also Community Access and the CCIT NYC. Yes, the coalition. And so thank you so much, Solomon from the Public Advocate's Office, Alex Vitale from Brooklyn College, Felix Guzman, who's an organizer with Vocal and a poet, and Peggy Herrera, who is just a mother on a mission, an organizer with Freedom Agenda, making sure that the family perspective is heard, and Anne-Marie from Cases, Chief Strategy Officer. So we want to thank you all for your voice and for really helping us talk more about this and really unpack what transformation could look like in our city. And so just to end, for those who are still with us, in New York City, the police and EMS responded to 154,000 calls to 911 for emergency behavioral health last year, okay? After the implementation of a true non-response system, however, the hope here is that these hundreds of thousands of calls will go to mental health response teams, to appropriate mental health care teams who are fully trained and equipped to handle crisis calls with care and be able to connect individuals with any resources that they may need in New York City. Nevertheless, it is up to us to ensure that our next leadership and our current one, while we still have them, you know, including the next mayor, the mayoral candidates, city council members, are on board with investing in an appropriate crisis response system, as well as resources such as those discussed throughout this panel. In order for this to happen, our city has to have the necessary tools to support the mental health community. And if you agree, we will be sending after this tomorrow the recording, as well as some follow-up action items, some ways that you can engage those candidates who are running, as well as current elected officials. And as always, NAMI-NYC is a resource to you, your family members, and other loved ones in your community with lived mental illness, lived experience. So if you ever need help or resources, help just navigating this wild system, please dial 212-684-3264, or you can email us at helpline@naminyc.org. Thank you all for participating and for being part of this panel. Bye all.
Thank you.
Thank you.
Thank you. Bye all.
Thank you, everyone. Bye.
Thank
everyone.
you.
Thank you all.
Thank you, everyone.
Bye.
Thank you.